I'm Dr. Trupti Gadkari. Today we'll talk on the tinnitus and it's not next slide. Yeah. Tinnitus and its management 360 degrees. Introduction. The management of tinnitus is both challenging and intriguing. Tinnitus is a common problem with an extensive differential mechanism. It is pulsatile or non-pulsatile is important distinction. Will only become more common with aging of our population. Peripheral and central mechanisms are working together in causing tinnitus. In most, if not in all cases, tinnitus is triggered by a lesion to the auditory periphery. Now the causes of tinnitus, they are the subjective or the objective. Subjective causes are otologic, that is a hearing loss, that is presbyocusis, noise exposure, otosclerosis, Meniere's disease and acoustic neuroma. Ototoxic drugs or substances, neurological multiple sclerosis, head trauma, metabolic thyroid disorders, hyperlipidemia, psychiatric depression and anxiety, and infection like syphilis, meningitis. Objective are AV malformation, vascular tumor, venous hum, atherosclerosis, ectopic carotid artery, persistent stapedial artery, dehiscent jugular bulb, vascular loops, and in condition like pregnancy, anemia, thyrotoxicosis, benign intracranial hypertension. We have studied total number of 25 cases, out of which otologic are 17, due to noise exposure there are 13, presbyocusis 2, trauma 5, otosclerosis 1, psychiatric 1 and Meniere's disease 3 cases. Now mechanism of tinnitus generation. There is an alteration in metabolite cycle of glutamate leading to excessive glutamate, cortical reorganization and neuronal plasticity. There is an abnormal electrical activity in central auditory system, mechanical trauma to the receptor, damage in the auditory pathway. Persistence of systemic disorder, they are the responsible for the damage. From the history of all patients, more than 70% presented with a whistling sound in the ear, as well as other with different noise, were provisionally diagnosed as tinnitus. They are evaluated and treated accordingly. More in left ear compared to the right. Most common in 40 to 70 year age group and more common in men than in women. Now evaluation. Careful history of tinnitus was taken regarding quality, pitch, loudness, if it is constant, intermittent, onset. Then elevating factor like applying pressure at the side of neck, then Valsalva maneuver in vascular causes. Aggravating factor like smoking in cochlear pathology and ototoxicity, the yawning and blowing of eustachian tube dysfunction. Now evaluation by history like infection, trauma, noise exposure, medication uses, medical history, hearing loss, vertigo, pain, family history and impact on patient. Now evaluation by physical examination, complete ENT head and neck examination done, general physical examination, otoscopy done to rule out glomus tympanicum and dehiscent jugular bulb. There is a search for audible brew in pulsatile tinnitus that you auscultate over orbit, mastoid process, skull, neck, heart using bell and diaphragm of the stethoscope. Evaluation by audiometry. Then pure tone audiometry and impedance is done to assess the sensitivity of hearing and compliance. Tympanometry and stapedial reflex test to identify the middle ear pathology and evaluate the neural pathway for stapedial reflex. Then OAE to obtain the additional information on cochlear and efferent function. Auditory brainstem evoke response to exclude the retrocochlear pathology. Now the measurement of tinnitus. Measurement of tinnitus include pitch estimation. High-pitched tinnitus is common in patients with noise-induced hearing loss and low-pitched tinnitus is commonly seen in Meniere's disease. The patient is asked to match the tinnitus frequency with that of pure tone frequency. Then loudness. In tinnitus, loudness match, the patient is instructed to match the loudness of tinnitus with that of a narrow band noise generated at about the same frequency as that of tinnitus. Tinnitus loudness is defined as a magnitude of intensity of tinnitus and this is an index of number of nerve fibers involved. Then masking refer to the reduction of audibility of tinnitus when the patient is exposed to another sound. This is known as a tinnitus masking. The instrument used is known as a tinnitus masker. Measuring tinnitus serves to authenticate the presence of tinnitus and help in deciding the optimal treatment modality. Then we do the laboratory study as indicated by history and physical examination, then hematocrit, FTA absorption test in syphilis, blood chemistry, thyroid studies, lipid profile. Now treatment. Now three kind of treatment given. Injection caroverine as a single dose therapy along with a capsule caroverine to 10 patients. One injection, that is 8 ml, contains 160 milligram, and that is given in 100 ml of normal saline is given at the rate of 2 ml per minute till the therapeutic effect is achieved or total solution is injected. Now inclusion criteria for this: age of the patient between 18 to 60 years, diagnosis of tinnitus, unilateral and bilateral, cochlear hearing defect, audiometry confirming the cochlear synaptic tinnitus and excluding the middle ear tinnitus. Now result of treatment: injection caroverine, immediate relief on infusion. 4 patients out of 10 patients on follow-up. Out of these 4 patients, 2 patients of them had a further reduction of sound and 2 had no further improvement. And out of 6 patients, 4 of them had a gradual improvement, 2 had no response even after 3 months of treatment with the capsule. Then ginkgo biloba and multivitamin. Out of 10 patients, 5 of them had a satisfactory relief, 2 of the rest 5 had a mixed result, and 3 of no improvement at all. Then we have given a combination of both is given to 5 patients, out of which 3 were having a satisfactory result and 2 were with very less improvement. Now follow-up observation, that is a grading of tinnitus done from 1 to 10, then pure tone audiometry, or you have to see any side effect. This was done immediately after injection, then 1 week after and 4 weeks after the treatment. Now the prevention: use hearing protection to avoid loud and unwanted noise, avoid possible irritants, take care of your cardiovascular health, cover up the noise, manage stress and reduce your alcohol intake. Conclusion: in this study, 14 patients out of 25 responded. 50% with injection caroverine followed by capsule, 50% with ginkgo biloba and multivitamins, and 60% with combination. More patients reported significant reduction in follow-up period of 4 weeks. No side effects were noticed with the above treatment. Overall, cochlear tinnitus can be treated with glutamate antagonists like caroverine and ginkgo biloba. There is a great evidence that hearing loss and tinnitus reflects glutamatergic neurotoxicity of the peripheral dendrites of the primary auditory neurons. Non-responder may be non-CST pathophysiology that was not detected in diagnostic procedure, or a tinnitus origin may be in the brain auditory nuclei in addition to primary peripheral tinnitus origin. Research into mechanism and treatment is needed for better health of our patients. Thank you very much.
I request Dr. Gaurav Agrawal to hand over the certificate to Dr. Trupti Gadkari.